ultrasound and aesthetics expert sonographer's perspective. So thanks very much again for joining us tonight, Lisa. So
you're welcome.
Thank you. So I'll just talk a little bit about your background. Lisa, you're Associate Conjoint Lecturer for UNSW, PhD candidate at the moment. So you're doing your PhD on shoulder ultrasound, is that right?
Yeah, the healing shoulder.
Yeah, and multi-award-winning researcher and sonographer. So I found this article in the paper. So medical professional from Cogra wins top award. What was that one for?
Oh, that was for being sonographer of the year. Yeah.
Yeah,
so
fantastic. You've won a couple of them, right?
I have. Yes. Yeah.
Sonographer of the year, researcher of the year.
Tutor of the year. Yeah.
Tell us a bit about your background. How did you get into ultrasound?
Well, I was a radiographer first, and then, you know, I sort of like talking to people, obviously, and I was fortunate enough to be able to go into watch a girl do ultrasound, and I fell in love with it. And what I fell in love with was the fact that you could actually see inside people and you could see how things moved. And then at the same time as engaging with people, you could actually watch how things move, which could give you a better concept of what was going on. And then it just advanced. So literally when I first started, there was no ultrasound course to speak of. I started doing ultrasound in 1988. I know I only look about 40, 30, but started really early and learned on the job, which is, in my opinion, the best way. Worked very closely with radiologists. And then in 1993, I was offered a job in the city in Sydney, in Macquarie Street, working in MSK, which was 10 years of hands. So 10 years of hands, and the depth and structures of the hands are very, very similar to that of the face. So that's how I started. And then I just eventually went from doing hands and working with hand surgeons and having the opportunity to go to theatre. Then I went in to see what was inside and then apply that to what I could see on ultrasound so I could work what structures were what. And then I just sort of progressed to the way of just...
At that time with hands, I mean, now, there's a lot of resources to learn about ultrasound of the hands. At that time, you're saying you had to actually go, and you were not making it up as you went.
I was one of probably 2 sonographers in Australia doing any hand ultrasound, and I was the only one in New South Wales. Actually, no, the only one I think on the I think I was the only one fortunate enough to be able to work specifically with hand surgeons because they were very interested in ultrasound. So when you have that interest, then things seem to correlate and move very fast. So you learn a lot from the actual surgeon as opposed to a radiologist / doctor, because they're the ones operating on these things. And that was big. And the reason why ultrasound was so big in Australia, and that was 1993, but the reason why is because we didn't have MRI.
Oh, okay.
So yeah, that's the reason. So MRI actually didn't come into Australia, I don't think, till probably another maybe 5-6 years, and at that time it was very, very expensive. So ultrasound sort of came into its own, and through trial and error and people wanting to learn, it took a life of its own, and where we are today. It's good. That's the good thing about it. It can sort of like sort of modify and collate, if you like, into whatever you're doing with soft tissue, anything above bone. It's a great modality.
Yeah. And so what does a current week look like for you at the moment? What are you doing on a regular basis now?
Okay, well, I do a couple of things. So I am, like you were saying before, I'm finishing my doctorate with my shoulder ultrasound. So I used to work with a shoulder surgeon for like almost 15 and a half years. So he's still my supervisor. I go and help out with him sometimes. I'm very involved in fertility scanning, so IVF, and I do a lot of education in IVF. I work in rheumatology, so I do PRP for tendon help, and I use ultrasound to diagnose disease and activity. I and I also do a lot of education, and I work general MSK and a
Yeah,
bit of
cool.
sports
So
stuff these days. A lot of them do their own now, though.
yeah, so still a lot of clinical, a lot of research and
Oh,
teaching.
heaps.
So,
Yeah.
yeah,
Always
yeah,
clinical to
excellent,
keep it relevant. Yeah.
awesome. Now
Yeah.
we've got this research study up for you. This is one of a group of studies I think that you've been working on. Do you want to tell us a
Yeah.
little bit about this?
Okay. So basically, this is using ultrasound to track the post-rotator cuff tendon. So you've had your shoulder reconstructed. So I've tracked how the tendon actually heals over a 12-month period at specific time points. And they are the time points in which we assess our patients post-operatively to see and gauge how they are recovering. So my job is to scan the shoulder, and we used to we look at black, whites and greys, obviously, that's what we're doing. So it's called a grayscale ultrasound. But, and then we tracked it over time. Yeah. So for being with shoulders for a very long time and hands-on with my patients, and also going to theatre and doing their rehab with physios, I noticed that quite often, just because something appears to be a certain way doesn't necessarily mean clinically that it's failing or it's good. So I mean that by, if you have a look at this, can you see my arrow?
I
No.
can't, but you can tell me where you're
Okay,
pointing at.
so what you're on now is the suture. So
Yep.
when I look
Repair.
at specific, yeah. So when I look at the integrity of a tendon, I make sure that that suture material is actually within a tendon, because if it's not within a tendon or it's not within something, it's retorn. That's a given.
And this part from here to here is
Yep. So that's the
our
tendon.
rotator cuff.
Yep. Yep.
This
So
is our
that's the
bone.
supraspinatus tendon. Yep. And so that cruddy sort of bit is the anatomical footprint. Now, this is where the suture actually goes into the anatomical footprint, which is the bone, and the tendon is actually sort of like reintroduced through sutures and anchors and regrow it. It regrows, in a sense, back into the bone. However, they're not always successful, and tear size is a factor, age is a factor, but a lot of people used to rely on grayscale ultrasound, which is very observational, because it's up to your interpretation of black, whites and greys, where the people that are on or learning about this can appreciate that, and they give you a story. So with this, you looked at the tendon, you wanted to see if there was a bird's beak configuration, you wanted to make sure the suture was within the tendon, if the tendon itself was quite echogenic in saying that, you know, the pattern or the fibular echotexture was re-established. You want to make sure that the patient is also strong. So you look at your clinical assessments, also look at activation. So you use abduction, you use external rotation, you're looking at the way in which the deltoid, which is above or superior to that of the supraspinatus, actually activates in abduction. And you also, above that deltoid, you can see the bright interface, which is a fascial plane, and the grey stuff above that is the subcutaneous fat. And then the lighter area above that subcutaneous fat is the dermis of the skin. So pretty much everything that we see in the face is what you see right here. The only variation is that in the face, tendons don't insert into bone; they insert into fascia, or they insert into skin. So the bottom left, the green sort of thing, that's called a quality map. So you must use that. It's imperative that you use that to make sure that the area that you're actually sampling with this application called shear wave elastography, which gives actually the tissue a numeric value. And that's never been done before. You know,
So that's
people
the
talk.
value of stiffness, is it, Lisa? So
Yep,
it's basically
well,
telling you how stiff.
velocity.
Yeah.
Yeah,
Okay.
in velocity.
Yep.
So I measured velocity being speed, because I chose velocity over elasticity being kilopascals, because on ultrasound we look at black, whites and greys. So if the tendon is intact, it is bright and echogenic. So you would expect the sound to be very, very fast. And if the tendon is hypoechoic or heterogeneous, meaning there's bits of black, whites and greys and it's compressible, you would expect then the beam to be absorbed. So therefore the value is low. So a tendinopathic tendon is low, a nice healthy tendon is high. In a healing tendon, my thought process was, If it's just starting to heal, you would expect it to be soft. And then over a period of time, as it heals, it would become stiffer. So that was my research. And it's right. The tendon heals at different times. It heals at different parts of the actual tendon repair. It repairs faster at the lateral insertion, where the tendon goes into the bone, and then over a period of 12 months, the tendon then becomes stronger equally. So it's all a repair process, and we could see that on our numbers. But you must use that quality map, because if you don't have a beam that is optimal, you can't guarantee the values that you're getting, which is on the right of that, to be correct.
So am I right in saying this image on the left is a little bit like a control? It's
Correct.
kind of
Well,
just making not a control, but it's
it is in a sense, because if the area you're sampling is not green, you can't use that whatever you get, you can't use your values. So it's that level of it's called a signal to noise ratio graph, but it's there to make sure the quality of the beam is optimal.
Yeah. And what are these red? What's the red telling us? Is that telling us that it's stiffer
Stiff,
or not as stiff?
stiff. Yeah,
Okay.
no, stiff. So if you can see on the top black and white screen, I have a red square that defines the deltoid, and I have a green square that defines or outlines the humeral head. Now, they were my ranges. So a humeral head is bone, it's going to be stiff. So that's
down
10
here.
meters per second, correct? And then the deltoid is soft because it's muscle, so it's about 3 to 5. So for me to gauge the actual repair ring of the tendon, I had to have a range. And then I quantified and qualified that, and it was a reliable type of application and protocol. Then I placed the little squares, sample squares, which on the black and white again is labelled with an asterisk, being lateral 3 millimeters medial and 6 millimeters medial from the insertion. And that had to be away from the suture, because if it's placed over the suture, it's going to give the incorrect value.
Yeah,
That's what
fascinating.
I've done. Yeah, it's
I'm going to
unreal.
ask
It's
you
really
more
good.
about this later in terms of the face, but
Yeah.
let's move on. So this is you teaching at a couple of aesthetic workshops, I think earlier this year or maybe last year even. What was it that got you interested? How did you get interested in aesthetic ultrasound? You got this huge MSK background. You've done a lot of fascinating things with ultrasound in general, but what was it about aesthetics that made you say, yeah, I need to get into this?
There's a couple of reasons. I thought, because I'm very much safety conscious and accuracy conscious and patient outcome conscious. So I know that, with any woman knows that, like, a lot of people are doing injectables. It's not just Botox, but there's a whole lot of other things. And then I sort of heard that, people are using it for therapeutic types of things like macetotoxin. They're starting to do trapezius toxin. We can talk about that another time, but all these sort of things. And I started thinking, wow, what does that mean? So then I realized, well, you can easily see muscles, you can see tendons, you can see fascia, you can see fat. And I thought possibly ultrasound would have a place for the injectors or surgeons or whatever. So I went to the Cosmeticon conference before COVID just to see if there was a place that I thought that there may be a place coming from my background. And I walked away from that meeting. I thought it was so interesting. And I thought there's definitely a place for this type of ultrasound for a whole gamut of reasons. And there's so much to learn. So yeah, that's how, and I'm fascinated. There's so many things in the face that are so much more exciting to see, but also the skill that the injectors have with the depth of their needle placement and stuff. It's phenomenal. And it's great. It's really good. So their visual identification, I guess, from experience of knowing where potentially vascular pathways are, what fat sort of looks like looking at the skin, is remarkable, because I can see all that on the inside. So it just sort of married, and I have it's a huge interest now in ultrasound.
I agree.
For the face.
I remember us talking about it before Cosmeticon, and
a couple of years before that, right?
Yeah, we both went to that together. And I agree.
Yes.
I've actually never really seen many better use cases for ultrasound than facial aesthetics for all the reasons you just said. You're talking about, you know, injecting things into areas where there's potential possible for risk, and it's just such a valuable tool to be able to. You can see everything. There's no
Yes, you
guessing.
can.
There's no need
And
to
the
guess.
depth, yeah, the
Yep.
depth, it's just so minimal, you know.
Yeah.
Like I thought the supraspinatus tendon was smaller. I thought digital nerves were
Yeah.
small, you know,
Yep.
which the digital nerves are small, but you know, the nerves in the face are even smaller, obviously, because they're tiny. So
Yep.
it's just, you know, and it's amazing how ultrasound is that type of application that magnifies things
Yeah.
extensively, you know. Yeah, and you
So
can move, everything can move and glide. Yeah, it's
yeah,
good.
and look, in medicine, there can be a tendency for certain groups to maybe protect their turf. Do
Mhm.
you think that injectors should be using, as a sonographer, do you think injectors should be using ultrasound?
Look, I think, look, obviously I'm a sonographer fan, but to be honest, I feel like I really do think it has a place. I understand that, you know, it's workflow, that you have to learn the foundation correctly. Once you learn the foundation, you will go great guns. I feel that the systems that are available with wonderful resolution, such as the VINNO, that's why I like using your system, because it's so affordable. The resolution is amazing. It's light, it's easy, it's non-invasive, and it gives clarity to both the injectors and the patient. You know, so I personally feel that there's a very big role for ultrasound in facial aesthetics. I think it's a part of medicine. Actually, I think this reminds me of how MSK first started. No one thought it was going to be great. They were like, it's a waste of time. Well, look at it now. 20, 30 years later, everybody does MSK, you know,
Yeah,
and the same thing I feel is going to happen with facial aesthetics. I think it will become one of those practical applications that the majority, not all, but I think the majority of people may find that they are going to go, great, there's so many applications that can be used with it, you
yeah,
know. So
and
I don't like to say to a group of clinicians that have been doing something for a long time without seeing inside, I think you should do it. But
yeah,
I can strongly suggest that I personally, from my experience, can see it nothing but an advantage for everybody concerned.
yeah, for
Yeah,
sure. And
yeah.
in your experience, do you think everyone can learn ultrasound, or do you think there are some people who get it, some people don't get it? What's been your experience over the years?
What you said second lastly, I think it's one of those things, not everybody gets it. So not all sonographers get it, you know, and that's why they don't do it anymore, because it's you know, if you like Salvador Dali, you're going to be great, you know, because you can work out the pixels. But yeah, I don't think everybody can get it straight away. I think a lot of people can, but you
Yeah,
know, once you apply your craft that you already know to visually working out what you're seeing inside, I think it makes it a little bit easier. But it's not for
yeah.
everybody.
Okay.
I think it has a
Um,
role though.
One thing that has been really interesting to me coming into the aesthetic industry in the last couple of years, and it's something that I'd never seen in any other, specialty before, was that you have groups who are very much for ultrasound, but then you have groups who are very much against ultrasound as well, which I found really fascinating because even as you say, some, in other, specialties, say, for example, MSK, MSK is probably a bad example because most people use it, but there are some specialties where some people use ultrasound, they love it, and some people don't. But I'd never heard this argument before where it was like, no, ultrasound is bad. You can't use it, that type of thing.
Oh,
Have you ever come across that before?
yeah, yeah, that happened to me with MSK in the very beginning.
Really?
Yeah, I left my job and I went to work in Macquarie Street, and everybody told me I was a fool. You know, you won't have a job in 6 months. MSK, it's a waste of time. No one's going to be able to use it. It's going to have no place. Same as in, anesthetics with,
Wow.
nerve blocks and stuff. No, you've got to use nerve conduction. Yep, yep, yep. Our ultrasound, you can't see the brachial plexus. Well, hello. All their injections now are done under ultrasound guidance, you know, but actually I don't know any anesthesiast who does modern day anesthesiast who doesn't use ultrasound anymore to guide.
Well, I was asking an anaesthetist about this recently about doing a central line without ultrasound guidance, which they would have done in the past, right? And
Yeah.
I said, and he's like, yeah, that's easy. And I said, well, why wouldn't you just do it without ultrasound? He said, well, it's easy for me, but if something went wrong, it would be indefensible. I couldn't explain that away. So
That's
I
exactly
thought
right.
that was really interesting.
Yeah.
Which is another, I'd love to ask you this question. Obviously, it's not a medico-legal expert, but do you think in the future, maybe 5 years, 10 years down the track, if you do have most people using ultrasound in aesthetics, would it be defensible if you had a VO, for example, you made somebody blind and you didn't use ultrasound? Do you think that could be a potential 5 years, 10 years from now?
Um, I don't know how to answer that one.
I
Because
don't know either.
yeah, right. I don't know that. Look, for me, I just think it gives you peace of mind, knowing that no matter what you've done, you've seen it, you've assessed it. So the good thing about ultrasound too, you can take pictures proving where you are.
Yep.
It's all that sort of stuff. So God forbid if something did happen, it may not even be your fault. It could have been a reaction to filler that the patient actually gets, and it causes these sort of things, which does happen. That's not the injector's fault. So litigation wise, look, anybody litigates these days. So I think it's always good. The thing is though, ultrasound has hit this medical space like a tsunami. Like it's and I mean that in the sense that it's so great for me and you, but it's just like, the want of knowledge, and that's a variable thing. Knowledge is the key, right? Correct knowledge, correct understanding of this application, but it's just taken literally by storm, and
Yeah.
so many people are interested in it. But in saying that though too, I mean, litigation wise, well, I just think peace of mind. If you've got the ultrasound system and you're learning how to do it, you will do it in your practice anyway, because it'll just become second nature for you, and you just take a picture proving where you are.
Yeah. Yeah.
So I
And so
can't answer the litigation sort of one,
no, it's
but the
probably
way
not
the
the right
world
question,
goes, I
but
mean,
yeah.
anybody can get around anything, right? It's always good to cover yourself.
Yeah, true.
Yeah.
So you're working with a few different injectors in the education
Yep.
space and teaching. So what are you coming across in the field at the moment? What are injectors doing really well when it comes to ultrasound? And what are some of the things from your background as an expert sonographer? What are some of the things they can improve on?
Okay, I think whether I work specifically with Lou Farah, and I work out of her clinic, and I find her personally to be a she's a wonderful injector. And this is what I've noticed with all the people that I've worked with, they all have a very good eye. They have a good eye, number one. Now, when you're injecting under ultrasound, that's a next level technique, because it's a very superficial injection type of injection site. So you have to be literally just under the skin, and you've got to have your little fine needle that's a very small gauge and very short in length, specifically like horizontal, so we can see it on the beam, and Lou's really good like that. So we scan everybody that comes through. We just don't do it for vascular mapping. If someone's going in to get their lips done or whatever, of course we always go around and have a look at the lips, number one, because that to me, that vascularity of the lips is so variable, and that's where I think ultrasound really does play have a place. I think around the piriform space too. We're looking for previous product. That's what we will do. And I worked with another lady, Jessica Maggs, in Melbourne, and she is using her ultrasound for the biofilms, like the Profilo, and looking at the difference in skin tissue, and that's revolutionary, because you can really see the changes. So I've been very blessed with the people that I've actually been around and working with. They've all got their techniques and their reason for using ultrasound, which makes my heart full, because there are so many things to do. But the only thing I find that perhaps is a little bit challenging is because there's so much out there now on social media, which is wonderful. However, terminology is a big thing, and we shouldn't worry about the terminology per se. Just stick to what you see, because ultrasound is a descriptive. It's an observation, so you describe it. So sometimes certain things are called, like for example, like the lymph node. There's always a lymph node at the parotid. It's not filler, you know. So if you don't angle your probe correctly, or your pressure is too hard, etc., you may, if you're not experienced, think it's filler, which it can look like, you know. So these are the things that I find are sort of not known well enough, and other things such as depth of the ultrasound, like using the ultrasound, using the correct ultrasound, working out what is needed. So structures, yeah, the structures are yeah, so describing the dermis, and then like it's like a cake. So you have your dermis, and these bright white lines that are horizontal, that aren't disrupted, are fascial bands, or the interfaces. So all around the face, all around the body, we have these bright bands or fascia which hold muscles, etc., together, and they all have functions. The face also too has different types of fat. So the subcutaneous fat is grayer and more compressible than the deep buccal fat, which is more of a shock absorber, and that's brighter. So these are the things sometimes that are perhaps being not identified, or you know, maybe confused. You know, certain parts of the masseter muscle, like the big round thing that comes together, depending on the view you're in, is the musculotendinous junction. You know, it's not actually a muscle belly that's broken in sort of sections. So I think,
is it more of a you know, just knowing the correct terminology and having a systematic way of dissecting the image?
I think that could help, but before you even go systematic and structurally like that, you've got to understand what it does. So you've got to understand your anatomy of the face, where something's going to be. Like you have your mandible, you have your masseter, superior to the masseter is the parotid, back to that is the TMJ joint. So you have your landmarks that don't change. So once you are familiar with those landmarks on an ultrasound image, and the plane being longitudinal to the structure or transverse to the structure, if you get that down pat, then you can work your way out, because you know exactly what structures are going to be there.
Yeah. So do you think some of it is coming from maybe people see a certain scan on social media, for example, which isn't 100% accurate, and then they replicate it? And
unfortunately, I think that's why we started having this conversation, right?
I mean, we have lots of conversations about aesthetics all the time.
I know.
But yeah, so I mean, where do you see
that's
things
a little bit concerning for me? That's all.
Yeah, right.
Because I
just
look
in
at
terms
something,
of
so I think, oh, maybe that's not, you know, right. Because, you know, on ultrasound as well, like, for example, if you're going to inject under ultrasound guidance, the substance that you inject will always reflect bright within it, because it's air bubbles. And on a static image, that can look like microcalcification. That can then be misconstrued into something else. And you can't always determine, that's on any ultrasound, you can't always determine what that picture means, because you don't have the clinical reference.
Still images, you know, unless they're a very standardized view, are almost, you know, they're very, very difficult to interpret, especially in the face. But
unless you have your landmarks.
Exactly. And where do you see, you know, the aesthetic ultrasound field going in the next 10 years? What can you picture in the next 10 years? Will people be like Jess, finding new uses for it, you know, looking at different types of products? Will people be guiding injections? What do you see the big changes being in the next 10 years based on your experience?
Yeah. So personally, for me, I would I think ultrasound really has a place here. I really do. It does. I think it's going to help in accuracy of needle guidance, whatever capacity you want to do. That's fine. It's all about depth and identifying structures. I think it's got a role already in looking at the face to see previous product, because a lot of clients don't know what they've had or how long ago. That's very, very important. You also want to be able to determine like what the muscle, if you're doing massive, for example, you want to understand how that activates and with the temporalis. So you want to learn how to sort of navigate your way around that so you can do the correct treatment for them. Yeah, I can see that in the future, ultrasound can also be used for not just occlusions and mapping, but looking at different product and seeing how it reacts to the product and how the skin actually reacts to that. I think it's got a very, very big opening in assessing fat, subcutaneous fat for these biomodulators. I think it really has a role there, and I think that eventually it's going to be used for complications, which it already is, but that's a different type of technique and skill that you do require. And normally, unless you're a radiologist, you sort of need to have two hands. It just makes it a hell of a lot easier. But I feel that in the next 10 years, ultrasound is really going to be a main part of aesthetics, just like it is for MSK.
Yeah. Can we just talk about fat for 1 second?
Yeah.
In MSK, fat plays an important role in diagnosing certain conditions, especially in the hand, right? So you see
Achilles.
Achilles. So basically what happens is when there's pathology, you have changes in the fat, even though the fat is not associated or, is not a part of that pathology, right?
So, well, yes and no. So when you have edema in the skin, what happens on ultrasound, that fat becomes more black. So it becomes more hypoechoic. So that's number one. That's edema. Sometimes you look like you've got rivers of water in there. Yeah. Now, if you've got reaction in fat, it becomes bright and echogenic.
Yep.
And then you can move forward ahead. And if it's inflammatory, it doesn't always have to have power Doppler and vascularity. It's non-compressible.
And we're going to look at some images of fat in a little bit as well, and we're going to see some changes in that. So I think that's going to be quite interesting to look at as well.
Yeah.
Let's just talk really quickly. We've got some people I know who are on the webinar tonight who are thinking about different types of ultrasound machines. I know that you're very experienced in terms of your sonography background. You use Siemens for your shoulder study. You've done GE with the IVF stuff, and obviously you've used VINNO with MSK anesthetics.
And
talk
Canon
to us
and Tosh,
and every brand, of course. So tell us a bit about what's important, because there are, in aesthetics, there's really only a few manufacturers who are active in the aesthetic market who've actually made products that are suitable for the aesthetic market, in my opinion, and who can provide support for that. So, because I've heard stories recently, people have gone out, they bought a unit, it wasn't suitable for aesthetics for whatever reason, and, you're stuck with it. So what should people be looking for?
Okay. All right, so people should be looking for number one, are they going to use ultrasound, and to what capacity in your practice and business? Because when you do this, ultimately it comes down to you also making money. So what you want to do is, look, I'll be honest, I've only, prior to doing some stuff when I first met you, like at that sports conference all those years ago, and you had a portable system, it blew my mind. So, which it did, and that's how we started our affiliation. But I've always used high-end systems. So such as the system on the left, I've used high-end systems, which are about 180 grand. God, when I first started, they were 250,000. That was a Philips. And that we used to only have the Linear Pro, being these ones, the little handhelds. They were the only ones available for muscular ultrasound. And then the hockey sticks came in. That was for something different. It's better dexterity, but I don't rate the hockey stick for the face. So you've got these high-end systems, which this one that you have is in my opinion, because I've trialed it, comparable to the GE. And that's a big call, because I like the GE MSK, but this, for the price and the movement of the being able to get around the console, it's amazing. These little handhelds that you have, both the wireless and the wired ones, to me, they're unreal. They are cheaper, and this is what everybody has to work out. You get what you paid for. So you are not going to get an image like you do on this V6, that vascular. Your image is not going to be as bright and crisp as this. On the handheld, you can get it pretty much to that. but your image quality won't be the same, nor will that image be like that on the big system, because it'll be better again. So this is where I'm finding a lot of injectors are getting sort of maybe sucked in a bit, like you said, come and buy this, it's great, it's all good, we'll support you. Well, like, hello, you go to support them and there's like crickets, no one's there, because they've sold you a system that's $3,500 that doesn't do anything, and it's really hard to get your money back. So you have to look at price. So you get what you pay for. You want to have you want to be able to have a system that is reliable, number one. Number two, that the images are nice and clear and easy to access. Ideally, you'd like to have some sort of backup system where you can save your images, and dexterity. So dexterity, I mean, for these handhelds, the lightness of the probe, these don't overheat like some others do. This is really light. You don't get RSI. You can rest it on the patient's face without it feeling heavy on them, and it's got a nice footprint. So it's price, understanding what you're going to get for that price. You want good backup. If you have a big cart system, or you have the portable system, you want to make sure that the monitor is easily to maneuver, and you want to be able to move around the actual knobs and that yourself, so you don't get confused, or there's not too many buttons that you fiddle around with. So you want good color, you want good resolution, you want good depth, and you want great images for the price.
Yep. So yeah, I mean, it's a really interesting question. We get it all the time. I think most people these days look towards a handheld because, again, I think they have been popularized quite a lot, mainly on socials, and there are some that are very good. And this new wireless handheld, it is surprisingly good. So we might just go ahead and
actually
have a look at some of
just
this.
go back. I just wanted to also say too, like, the most important thing with any ultrasound system, with anything you use, you need to have correct education to how you work it. So when it comes to ultrasound, that's another thing that I found that injectors they get lost with, is the depth. We have to remember the face is very, very superficial. You don't have your depth set at 6 centimeters, because, which I've seen on social media. You have it set no more than 3 centimeters, depending on how, a big man's face, or a big masseter, you might be maximum 5 centimeters if they're like bodybuilder or whatever. But you have to set your depth accordingly. And that's very, very important. And the gain is so important. Like where you have the gain or the TGC on the left-hand side of your portable system there, it should actually be pretty much in the middle. You've got to understand the knobology of your system to get the best resolution / image that you can get. You don't want it too bright. You don't want it too dark. You don't want it fiddly. Correct depth, correct pressure, correct probe selection, and correct gain.
Yeah, the education, it's so important.
Oh, so important.
Let's talk a little bit about ultrasound imaging. I know some people are very experienced on the webinar already who've looked at a lot of different ultrasounds, but do you want to just talk us through, what we should be looking at? This is a massive muscle, but
you've just told.
I'm sorry.
It's a muscle. Looks like steak. It's exactly what muscle is. It's steak. So where you've got your little red dot, okay, the bright area is there. So that's a musculotendinous junction. They're the bright fibers of the muscle that allow it to activate. Now, in an atrophic muscle, you don't have those bright white lines through a muscle. Okay, you don't have these bright white lines within the muscle, show that the muscle is actually a strong muscle. When you have decreased echogenicity or lack of fibular echotexture, the muscle's not good. Okay, that's another teaching thing. Above the muscle, though, you have this bright white line. So where the steak is with that nice piece of fat on the top, that is a fascial band. Okay, it can be some people call it part of the SMAS, but it's a fascial band. It's the covering of the masseter. So that's a nice bright echogenic band which encapsulates the muscle, and fascia is 10 times more innervated than the surrounding muscle. So that's something to be mindful of. Deep to the muscle is the bright white line, continuous bright white line without anything underneath it. That is bone. That's the bone. So if we move up through the muscle, go across the fat, on top of the fat, we have the bright white line, which is the fascial band. Then we have this nice area of grey. Go back. Sorry. Okay, that we can do it on here. So the nice area of grey, okay, so the nice area of grey above, yes. So that's nice, healthy subcutaneous fat. Now, fat contains fibers, because if you go back and you remember your cadavers, the fat globules are yellow, but depending on the yellowness and the size of those globules, it tells you what the fat strength is like, what its integrity is like. And the same is like with ultrasound. So in fat, you will always get these little bright white lines, which is nice and healthy, and it's always, it's predominantly grey, and it's soft, so you can compress it. It's soft for a reason, because structures deep to that have to move. Also, if something happens to the skin or the dermis, you can infiltrate that. Now, it's like a buffer. So it's very, very important. And this is the money spinner, in my opinion, for facial ultrasound. And then above this nice grey area, you have, once again, a bright white line. It's not as bright as the fascia, but it's a bright white line. And what that is, that's the dermis. Dermis and epidermis of the skin. So like I said before, facial ultrasound or MSK ultrasound is just like a piece of cake. You have skin, you have a line. You have fat, you have a line. You have muscle, you have a line. Then you have bone. And in between there, you have vessels and nerves.
Yeah. So when you look at a picture like this that's on the screen as a sonographer, what's your process of analysing an image like this?
Okay, so doing what you're doing now. So I just have a look. I know that's longitudinal. I know that's a muscle deep. I know that's a bone. I know that the bright echogenic area that runs horizontally is a fascial band. I know it's a fascial band because it's bright echogenic, and you've got fibular echotexture throughout. And as you're moving, it's actually not gliding as well. It's sort of like bunching, like it's lifting. So it's a supporting structure. Then up above that, I have my fat, and then up above that, I have my. Oh yeah, okay. I was going further up. Yeah. So that's deep. That's some deep fat. That's fat, because as you can see, while that temporalis is moving, this is sort of bunching up. It's not gliding with. So it's a buffer. And then above that, we have the fascial band. Yeah. Beautiful. And then above that, we have the nice subcutaneous fat, and then we have our skin.
This image was from one of those little handhelds as well, by the way. So I think another thing that I like to point out is some of the handheld systems will give you very good vascular. They'll show up the vessels very well, which is great.
Yeah.
But you miss out on a lot of this detailed information.
Yeah.
So if you're looking for something that gives you a lot of information, then these are the type of systems that do that, because you can very clearly see, like you say, every single layer has a different appearance. Yeah.
And that's important in this field of medicine, actually. It's identifying the layers correctly. And then once you identify those layers correctly by knowing what black, whites, and greys mean. So any interface is a continual bright white line that is horizontal to the ultrasound beam. So once again, here we've got, you're filling it in. So we've got, okay. All right. So we've got the filler, and also little areas of the filler as well. There's quite a bit of filler. So notice how that tissue around the filler is quite diffuse as well, all around it. So it's grey, it's quite wavy. Yeah, so that's filler infiltration. So above this, though, if you go to the soft tissue, it's sort of more echogenic, isn't it? It's more brighter. So that could possibly, if that patient came back with like a reaction, I would say that was a reaction to the filler. And that's what reactive sort of tissue looks like. It becomes, particularly if you go to the right, see how it's all blended in. Yeah, see how it's smooth.
You can definitely see compared, to the previous image, where you can see a big difference in the layers.
Yes,
you can't see as much difference.
That's right. So it's, that's become very smooth. That's normally, if I'm looking for a foreign body, or I'm looking for, which are hard to see, you always look for a black area in the subcutaneous layer because that's a reaction. And then the soft tissue, being the fat, always changes its echogenicity, becomes brighter and it becomes less fibular. And in some cases, it becomes less compressible. Yeah.
Do we want to talk through these as well?
For sure. Sure. Well, we're showing that. That's a beautiful fascia there. We've got the nice fat. We're showing the nice vessel. And always remember too, when it comes to, see, what I try to shy away from, to be honest, is when I teach the injectors that ask for me, which is great, and I'm very grateful for it, I try not to get them to rely on the colour. I would like them to be able to identify the structure first if they can, and then heel toe their probe or articulate their probe and take their pressure off and see if that structure that they think is a vessel actually does elongate out to a vessel. And if it is, then I get them to put the colour on. And then with the colour, I get them, you know, to watch their pressure, to heel toe the probe. So that's a different type of application that you then have to learn. Yeah.
Yeah.
Because if you
and is that something that you do in your practice as well when you're,
always.
when you're, okay.
Always. It's a given. You must always compress. Some structures can compress, some don't. If the ones that don't compress are compressing, it's pathological.
Yeah.
You know, it changes its function.
Yeah, right.
Yeah. Yeah. Beautiful. Yeah. Okay, here's a classic example.
So I'll just mention quickly, this was a patient who had a small VO, and I'll run this through. The VO was not in, it was in the nose, but this patient had some filler in, let's see if I can pause this. Move this here. I've gone too far now.
This is a really nice case. I like this. This is classic. And this is what I see a lot of, not so much the compression occlusion, but more the change of tissue. And you get that change of the soft tissue every time you inject. It's really good.
I just need to keep playing it. So basically we'll check in for the return of blood flow, and there was a return of blood flow, but this patient had been flooded with dissolver, and the day before, and that had basically resolved the occlusion. But look how much filler is still in that piriform space. So
and look at the tissue.
This was not dissolved under ultrasound, but we checked it under ultrasound the next day. And as you can see, the tissue at the top here,
that's what happens
fairly
when
well
you use
blended.
Dissolving. Yeah.
So I thought that was quite an interesting one.
It's a nice case,
you can see how much filler is left even after a very thorough dissolving, and the patient did have a good result. This was the same patient, and this is a nice little bolus of filler under the spine of the nose as well. And we can see the columellar artery just above too. So we are seeing interesting things as we're ultrasounding, and I'm really interested to see what we're going to find over the next 5 years, 10 years with ultrasound, because it's all still relatively new. And Lisa, you're a big part of what you do these days is teaching. You do private teaching, is that right? And you do workshops as well.
I like to do. I run a 2-day course, and I only have 8 max, but 6 max really, because the way in which I teach is a sonographer's perspective. So I incorporate the knowledge of ultrasound, and I do it over 2 days. So it's very hands-on. It's very didactic in the sense that, if someone is already knowing something, well, we move on to something else. Or what I do, I tailor what I'm presenting to what they do in their practice. So, for example, if you're more into the biomodulators, we're going to learn everything there is to know about skin. I teach you how you assess skin before you even do anything, how you can do side-to-side comparisons, how you measure the depth, how you measure the dermis, how you look at the skin, how you look at all those other structures. Yeah. Then for the general or the other types, like a lot of people like just to do lips, so we concentrate on that. Or a lot of eyes, we go around the eyes, even do a bit of orbital ultrasound just to show what, the depth of the orbit itself. So yeah, I do mine over 2 days, but I don't stop literally until I know that person that I've taught is confident with their ultrasound. So I bring a system that you provide for me, which is unreal. And they either have their system or you kindly facilitate. And I find that very effective. Like I said, I like to do it over 2 days because it's a lot of information that is quite daunting, and yeah, you need to be hands-on as well as application of a system, and then work out how you're going to implement this into a practice. So I do that, and also we do the nice introductory, which I love. I think that's very, very nice for anybody that's thinking of doing ultrasound in their practice or in anything,
So that's
to
a
come in
4
and look
hour,
at these.
5 hour, 4 hour
Yeah.
workshop on a Saturday, the intro, and there's one coming up on the 25th of November in Sydney.
Yeah.
And
yeah.
for your personal, your private one-on-one training, you do that all over Australia. So
yes, yeah, and internationally.
Yep. And so if anybody wants to get in touch with you, this is your best contact method, Instagram, the Ultrasound Educator.
Sure.
All right.
Yeah.
So perfect. If anyone wants to get in touch. So
and then I'll just give my email. Yeah.
Perfect. Thanks so much for sharing all of your knowledge with us tonight. It's